I'd like to welcome our first guest this morning. He's currently the CEO of Kata Health, where he works with hospitals, health systems, and self-funded employers to improve access to high-quality care at a better price. Prior to Kata, he spent more than 20 years leading major hospitals and health systems, including serving as president of Beaumont Royal Oak, here locally. Let's welcome Shane Cerrone. The value that I believe of having an executive from any large health system or hospital, the value of having somebody who has that experience but is not tied in anymore and not currently has no allegiance per se. Let's lean in. So we're going to do maybe some light Q&A at the end if there's questions, but I would say also if a relevant question pops up, like raise your hand, like we want to hear it. As we prepped for this, Shane was giving me some coaching and said, let's make sure that people, we're not just throwing an agenda at them, but like if there's things that they want to know, we cover it. So, ground rules. Shane, go ahead. Why don't you introduce?
Okay, good morning, everybody. What was the good news yesterday economically in the country? Jobs report was pretty good. What's today's front headline on Wall Street Journal? It's all healthcare. So we're pretty much doom looped for costs for next year. So, but let's get into this. So I've been in Michigan for a long time. As was noted, I've been the CEO or president of 4 health systems or major hospitals, and I love that work. It's incredible industry, and I've always liked it. By far and away, the greatest privilege that I've ever had was serving as the president of Royal Oak, Beaumont. I mean, I left there a little over 10 years ago, and I was there for nearly 8 years, most of it in that role. And I learned a lot. A lot of my thoughts and comments today on the industry come from really that experience with Beaumont. And what I can tell you is this, 10 or 12 years ago, it was illegal for me as a hospital president to know what the other hospitals in the region were paid. It was anti-competitive. I mean, it was actually illegal for us to know that until the price transparency laws came along, and that changed all of it. So we never knew, how much we were paid relative to even the local market. But in my time at Beaumont, for lots of reasons I won't walk through here, we started to look at that very carefully in 2012, 2013. And what we realized was that we were paid much less at that time at Beaumont than most anyone in the country, and even less than a lot of players in this region, even though I would say to you, maybe today still, but at that time, I think Royal Oak was defensively the best hospital in the country. And I say that because we used to define the best hospital in the country as having all this incredible level of medical expertise and specialization. Beaumont ranks amongst the nation's best. And, I didn't create that. It's been that way for a long time. Certainly, it's a brand that people trusted locally here and should. But what most people didn't know is that our prices were far lower than everybody else. And I started to work in 2012 and 13 with big self-funded employers, think autos and others. And I tried to explain to them, if you could use your benefit design to steer your members to Beaumont, most of them like coming here anyway, you're going to save a fortune. And I learned that even then, at that time, even the big autos with healthcare staff had no idea what the price variability was in healthcare. And there was a leadership transition at Beaumont, and I took a plan for it, and I said, basically, I think we can go one of 2 ways. We're among the lowest paid in the region. We can either work with Blue Cross and others to try and increase our rates, and maybe we should, or we can steer more of the commercial business to us, and as our volumes grow, we'll be able to reduce our prices and pass that along to you. And the answer was basically, I don't know what you're talking about. And I left about 6 months later. And I'll just finish my opening comments with not many people are in your corner. Hospital CEOs are not trying to reduce prices. The market doesn't reward them. I was the president of one of the lowest priced great hospitals in the country. None of you steered business to me because of that. It's not your fault, but it didn't happen. And so healthcare executives are really not incentivized by the marketplace to drive down the cost of care. Nor are the insurance plan CEOs. They can only push on me so hard at Beaumont before we threaten to leave network or do whatever. And it's not just Beaumont, this plays out all over the country. And then the health plan CEO has to back off because you start to think, geez, do I need to switch cards for my members? We like going to Michigan or Beaumont or Cleveland Clinic or wherever. And if I'm a health insurance CEO, my job is to sell insurance. And who are the biggest employers in every town? Well, usually it's the health systems. So they're only going to go so hard on price when they see them also as potential customers. So what I mean to say all this is we've got a lot of great people in healthcare. I didn't come here today to talk about that, but it's true. We have wonderful people in healthcare, brilliant people, hardworking people. The market structure is designed for what we get every day. And there's no way costs won't go up next year unless the market is restructured. Most everything else, which can be good, is nibbling around the edge. And I'll let you go through your questions.
Are we done?
But there is a path. There is a way out of this, but please, go ahead.
No, I say that jokingly, but that pretty much sums it up. We're going to break into a couple other areas, but I do think that sums it up really well. That's powerful. I think just, again, for whatever reason, Shane, thanks for sharing that. Why is it so hard to get that? I don't know. The clarity of that message, I find sometimes is hard to get from the folks that you need it from. So thank you. Why don't, just to kind of set the baseline, let's talk about where the different streams are coming from a hospital, for example, where the customers, we've got patients that are commercially insured, right? We got Medicare, Medicaid patients, payer mix. We got that, maybe a potential visual we wanted to walk through as something we could do too.
You want to go through that now?
Yeah.
Sure. Why don't you, I don't know who has the exhibits.
I got it.
Can you just pull it up?
Yep.
So I'm just going to show you, this is Michigan today. This is based on data that comes from the RAND Research Corporation, which is, if you've heard of RAND, it's a major organization. They study prices on health systems around the country every year. Not that many people still follow this. It's just on their website. You can pull this off yourself. We're actually very lucky. Michigan's one of the lowest pay states in the country, so as much as healthcare costs here, it's a lot worse most everywhere else when you talk about price. But I just wanted to show you a few things here as relative points. So this is price for institutions as a ratio to what Medicare would pay that hospital. So to just kind of create a common standard for how expensive is it here. The yellows are really the Michigan hospitals. So you can see, I just picked some, Garden City, Sparrow, U of M, McLaren, Trinity, Henry Ford. And they're generally between 190 and 200% of Medicare's, meaning when patients come to us, we get paid about twice. For your members, you pay about twice what Medicare would pay us for the same services. This data is still true. This is what I was fighting about a decade ago. Beaumont, Troy, Beaumont, Royal Oak are still among the lowest in the state, among the lowest in the nation. Data is a couple years old. They run this data about every 2 or 3 years. It's the most recent data. If you want to go to Mayo Clinic, Cleveland Clinic, Northwestern, these are fine places, 250%, 300%, 350%. I tell people it's like buying a car for $50,000 at one place, $100,000 at another, and $130,000 for the same car. We would never tolerate this level of price disparity in anything else that we buy or consume. But this is the landscape that you're dealing with. Now, importantly, these are just averages. Within each of these institutions, if you dig into contracts, you will find radical variation and differences. Maybe they've negotiated crazy high rates for cancer care and low rates for outpatient primary care, or maybe vice versa. It all so you can't even. This is directionally true, but there's stuff going on underneath in these contracts that you don't have access to that I read from time to time. Knee implant, knee replacements. I think most of you know you pay more if that knee replacement is done in a hospital surgical center than you do if it's done in an independent or ambulatory surgery center. It's usually about a 50% price difference is what the market data shows. What you don't know is that some health plans include the implant cost in that rate, and some plans agree to have that implant cost be outside of that rate, meaning I'm going to get 200% of Medicare, plus you'll pay for the knee implant, which is the most expensive part of the whole thing. You would have no way of knowing all that's going on and moving underneath the contracts, but this is just a quick landscape of what's going on, and this is the picture of how we know the market's broken. We'd never see this price variability if health systems competed on price. And at the end of the day, that's my main message. Is it's not what I'm afraid of. It's like health systems should have to compete on price and quality, not just brand. But it's still not fixed. Even with the transparency laws, people don't shop on price. They can't yet today. So there's this.
Oh, great. To be clear, just for anybody, if you're wondering, or if you came in maybe not knowing as much, so the Medicare 100% here, obviously that's what the hospitals are paid for a given service, and then the commercially insured folks were paying on average twice as much. Mm-hmm. Yeah.
Yeah.
Okay. So, question.
Yeah. Sorry.
Just got a quick question. If you were to overlay quality on top of this, I think I know the answer to it. At a high level, I assume the quality would not be 3x better in the red zone.
I'm going to repeat the question for the recording purposes. The question is, the quality, does it reflect the price? Is there a correlation? That's the question, right?
Has nothing to do with it. And after this, I'm not going to ask him to speak now, but I do want to introduce my good friend and colleague, Dr. Sam Flanders. If you just raise your hand, Sam.
Let's get him up here. I'm just kidding.
Sam was the chief quality officer at Beaumont for all the years I was there. And I think he led one of the finest quality programs. He's a pediatrician, one of the best in the country. Year after year, Beaumont was ranked among the top institutions in the country for quality based on metrics that we as providers choose to follow, not what you see, but what we follow. And it was the lowest priced. There's plenty of research out there that the correlation is, I don't know that there's any correlation. I wouldn't even worry about it. I would not assume bad quality because the prices are low at all.
I'm taking silence for a second.
I can just go
When
on
I
if you want.
said asinine earlier, again, not to pour gasoline on the fire emotionally, but I think there's got to be a better way. Question? Because I heard you say something earlier, Shane. Or maybe it was in one of our previous conversations. Something along the lines of, I'm not putting words in your mouth, but it sounded like you're frustrated. If you want to grow and improve as a hospital, there's nothing you could do to, quote unquote, get more patients or serve more people in the traditional sense of, hey, everybody knows that we have a high quality standard, or our prices are super fair. There was nowhere you could go, is what I'm hearing you say, if you guys were one of the most affordable facilities. So I guess what I'm asking is, not were you frustrated by that, but a little bit more of an elaboration of what went into where you feel like you could go. I know you said you gave up 6 months later, but what does that have to?
Well, I just wanted to spend my time doing different things at that point. I thought Beaumont was the answer to the national healthcare crisis, honestly. And when it didn't seem like, I still love the place, so it's not. But when it didn't seem like that was the strategy, I just didn't want to spend my time doing that. I decided I'd go help other institutions, and that's what I did. And I've spent the 10 years since still talking with employer groups like this to try and just be an honest broker of information about how the industry works, what you can do to control costs, and how you get patients to. We want everyone to have the very best health care at the right price. And there's no reason in this country that we shouldn't have it. We do have one of the finest healthcare systems in the world in terms of the quality of care. But the reality is, when I run a hospital, how do I compete? I compete on, the reality is, as a hospital CEO, the patient's my customer, kind of. The doctors are my customer. Because the doctors tell you where to go for care, you generally follow their advice. And Beaumont's always had a winning strategy. We recruited wonderful doctors, and we had great training programs, and it had a great result. There was nothing wrong with that. But that's not how that's not how you or your members choose where to go. For us to get to a world where people include price, you've got to get into the primary care doctor's office, which I know there's a session afterwards, and they've got to become a critical part of the navigation of that. But we have to have a world where they understand the prices of the places where they want to send you. I always tell people, you can get an MRI for $3,000 or $1,000. I mean, there's huge price variability. I know there's other speakers talking about that today. The problem I see is that when you as a patient, when your doctor says to you or someone you love, hey, I want to run one more test, or you have a diagnosis, it's a really hard moment in people's lives. Even if it's going to be okay, it's scary and it's confusing. And it's not a moment where people are going to go home and spend 5 hours trying to figure out the prices at 5 different hospitals. Dr. Thomas says, hey, I want to send you here to this cardiologist to have a look. You're probably going to go there. And the only chance we have of steering people to value organizations, in my view, is if you as a patient had a benefit design that said, hey, Dr. Thomas, thanks for, I get it. I need an MRI. You recommended I go here. My tier 0 is this imaging center. I don't have copays or coinsurance there. The prices are lower. Would it be okay if I went there? And I'm picking on Dr. Thomas, so I don't know real well yet, but I've known of him for years. To me, the answer is sometimes Dr. Thomas will say, I really want you to go to this place because they specialize in this imaging. I want you to be there. It's the right place. Other times, Dr. Thomas will probably say, I don't care. That's fine. The MRI there is just fine. You can go there. And so we've got to steer at the point of the physician's office. Once I leave the office as a patient, all the functions and things that people spend money on in the world can only nibble around the edge of redirecting care. It's too late at that point, in my view. But I think there's a lot we can do to rewire healthcare to create that kind of model, which really would be the right care for people, as I see it.
Yeah. And what I'm hearing you say is not just, full access with no data, but I think we're going to get at this in our second session, but more of like an instance by instance on anytime something's going to happen. That's where the influence is when it comes to quality, price, and that's how we need to design things for us as, consumers, people that need care. That's what I'm hearing you say.
Yeah. I'll also tell you, because I know you get involved with these things, I think neural networks are a fool's chase. I know they sound great and they seem reasonable. I would never let any of my family be involved in a neural network. So you can take that as you will. They're great until you get sick. And the problem with neural networks that I see, and I don't think we have to have them to get to the end that we want either, is that a neural network, no hospital is the best at everything they do. Not Beaumont, not Mayo, not Johns Hopkins. And so when you create a neural network, you are creating a cap on the level of expertise and quality that your members can get. And I know why you would do that, but I would fight against it for the benefit of your family and your employees.
Not to beat a dead horse on the pricing, but as we think about this, and then we can move on to the next topic, what's it based on then? If Medicare is the baseline, what's the average of what's that based on? How are they coming up with that?
Hospitals' prices are based on whatever you're willing to pay. That's it. There's nothing else. Every team and every health system in the country You know, even as a CEO, I don't sit every day and I have a whole contracting team. I couldn't spend my whole day with all the things that go on in a hospital and a health system thinking about contracting. Every contracting team is designed to get the highest possible price they can get from each payer. It has nothing to do with my costs, and it has nothing to do with anything else. It's how much will you pay, which is why it goes up every year. Every business would do this, by the way, if they could. So I don't even think any of your businesses are any better. This is not about evil people again.
Nice.
If you had an industry where there was no limit to price and the customer was willing to pay it, you'd ask them to pay more too. So the missing link is price competition among these big health systems. And without that competition, we have to create that competition to achieve a different result. And we can. It can be done.
What did you say? How do you recommend? Well, we can give them hope and some of your ideas, things that you spoke with the national coalitions.
Yeah.
We can get into that. I was going to ask one question, though. Maybe it's rhetorical, because you said something. Whatever we're willing to pay. That was the comment, right? I guess rhetorically, I mean, there's already some people that are walking away from being insured in general. I'm not trying to open a can of worms there, but I guess the rhetorical question is, I mean, how willing? What's our cap on like how willing we are as employers and employees? How willing? What's the ceiling? Where's like a breaking point? I don't even know if that's a question for you, Shane. It's just something I'm thinking about as I hear him say that. That's where my head goes.
If I were designing a healthcare system, I would tell you to work with someone like Dr. Thomas. I would tell you that every one of your employees should have a primary care physician in a medical home. Even if they're not sick, they're healthy, they're young, I don't care. They should have a medical home. You want that relationship in place. I would tell you that as individual employers, there's almost nothing you can do to change pricing in healthcare. You can shop insurance companies and you can make better choices and worse choices, but you can't change the marketplace. Even the largest employer, some of the largest employers maybe could, but they haven't yet. But the good news is, I think a group of you could change the world. You do not understand the power you have collectively. Individually, collectively, the only people that health systems and insurance companies are fearful of is you. And the only thing you refuse to do, historically in my view, is work together to price things together. We at Kata Health are recommending, we're working with the National Alliance of Healthcare Purchasers. I don't know if any of you are members. We're working in a few different states to say, listen, you can set up I don't know if any of you use group purchasing organizations for your supplies or where you buy paper or any of those things. Just do it for healthcare. If you get enough lives in Southeast Michigan, prices will tumble down. Even though we're one of the lowest price markets in the country, it will tumble down. Just remember that every day we accept this price. Everyone says, what does it have to cost? Like, well, I've never turned anyone away at Medicare. I threatened to turn you away because you have 1,000 lives. You have 2,000 lives. If you had 40,000 lives in a group, I'd think twice about it as a health system. And General Motors proved the point 5 or 6 years ago when they went out to this market and said, we want to talk to each health system and come up with a new plan. I think every health system showed up to talk to GM. They picked one, Henry Ford's. They violated one of my primary rules, no narrow networks. And I haven't heard much about that plan since. I think I've heard maybe they've got 10,000 lives or something, which is fine. But if you get enough lives and you're willing to say, listen, we're going to run a reverse auction where instead of having the insurance company negotiate the rate with Beaumont and Michigan and Henry Ford and Trinity, we're asking the health systems to give us your price as a percent of Medicare, and then we will put you in a tier 1, tier 2, or tier 3 design as an employer. Make them come to you. And that's what Sam and I are working on, is trying to create that group purchasing organization in markets around the country to take pricing power back and give it to you as employers. That's a restructuring of the marketplace. Yes.
The question is Medicare pricing enough for a hospital to run profitably or like survive? That's the question, right? Yeah.
I don't think we know how efficient we could run our industry in this country. Like, I actually believe in free markets. I believe in innovation. And what I tell people is, every time a health system executive tells you, oh, I'll have to shut down hospitals, I'll go broke. They may do it, but I do turnarounds too. You can change the cost structure of these organizations much faster than people realize. There's a lot of expense that does not add value in these organizations. It's not at the bedside. And the biggest thing is, you want high volume centers because they become more efficient. Just like when you run a manufacturing plant, I can only assume that the plant that makes 200 cars a day instead of 100, your unit cost can go down. I mean, I've never been in manufacturing. It's no different in healthcare. You want high volume, and high volume centers tend to be high quality centers too. They do the same thing over and over again. So how low could it go? I don't know. I know you can do it at 150 because I've done it. And I would tell you that when I was there, I thought I could take 10 to 20% of cost out of one of the most affordable hospitals in the country and not miss a beat over time. But it was hard for me to do it because I wasn't rewarded as an organization for doing it. And so politically, you guys like me get fired all the time for trying to cut costs when you're making money. There's a lot of political forces. Like, unless the business is challenged, just like your business is, unless you're challenged to restructure your costs for your survival, you probably wouldn't work on it the same way either.
Yeah. I got one
Yeah.
more here, as we're going to be bumping up on time in a second.
Yeah, sure.
I think you brought it up, so maybe we can segue. What are these political issues you're talking about? Can we just call out the ABCs of the barriers to change that we have in the players, the consultants,
The real barrier
carriers?
to change is that if you, as a group of, if I took all of you as employers into a group and we sent out an RFP to the local health systems in this region and said, hey, we want to establish price as a percent of Medicare, there's a couple immediate barriers. Yes, hospital people like me will cry, and I can help you with that because I've done that work. The insurance companies will come along and say, they'll fight it because their power is based on the fact that they are the arbiter of price. I tell people, and I haven't done this today, I said, when we, what's your name, ma'am? Pam? Pam and I go to the same grocery store. We buy the same gallon of milk, the same pound of ground beef, the same loaf of bread. She pulls out Visa, I pull out MasterCard. What do we pay for those things? The same damn thing. If we walked into a hospital and she pulled out Blue and I pulled out United and we had the same MRI, it's, game over. We're going to pay radically different prices. We would never accept Visa or MasterCard negotiating our payment prices for us. We should require hospitals and health systems to simplify how they present their prices even more than we've done today, which can be done as a percent of Medicare. Let you design benefits, and prices will come crashing down. And to your point about how low they can go, I don't know, but when Luke said earlier, we transplant hearts, we treat cancer. Health systems are filled with some of the smartest, hardest working, oftentimes most honest people I've ever met in my life. They're, in general, wonderful, wonderful people. And when you run a hospital and people say, what do you do every day when you run a hospital? We solve problems, right? You come in with a problem, my knee hurts, I have a lump, whatever. We try and solve those problems. If we turn the focus on price among those same providers, they'll deconstruct it and take it apart. We've just never asked them to. I believe in them in every health system in the country. So the potential's all there. It's just restructuring and reorganizing how you organize yourselves. And it really is not as hard as you think, as I think people will tell you that it is. But insurance companies don't want you to do that because they keep about 15 cents on the dollar, right? So when prices go up, they actually make more money. And if they weren't setting prices, we would only need a few insurance companies in the country, which is probably what we should want. You know, you got Visa, MasterCard, American Express, Discover, whatever. I couldn't name 10. I mean, I'm sure there's out there, but we don't need all these insurance companies setting prices. That's the problem. We need prices pushed on the marketplace, labeled on the shelf for all to see. We can get there through legislative efforts. We're doing some advocacy work to try and help some legislators write legislation that would mandate that. But you don't even have to wait for that. If you get together and have enough lives in Southeast Michigan, we can get there as a group of employers. It can be consumer-led, and I would suggest to you it's probably the faster way to get to it.
Perfect.
Time?
Yeah, we're right on. Look, give us 30 seconds. Yep, 30 seconds. If you were everybody's walking out, what's the message? What's the message that people cannot forget? If we just talked about a lot, 30-second message. Hey, I'm dying to just teach you something about everything I know. I'm Shane. What's the message?
Work with the Economic Alliance for Michigan, step one, and try and form a group GPO of your members in Southeast Michigan. It's not that hard. That's step one. Until you have that, your broker, and I appreciate you all hosting this today, a very honest conversation. The best you can do is navigate prices and know what you're doing and where your members live and where they go, and try and design benefits to send them to the more efficient things, but I wouldn't do the narrow model. And I would look to people like Dr. Thomas. And again, we've only emailed 10 years ago. He emailed me when he was starting his business. I should have gotten to know him better, but I'm looking forward to hearing what he has to say. But work with an independent primary care community. It's not a big community, unfortunately. It needs to be bigger. But attach yourself, and especially your most complex patients, to a good medical home model like that so they're getting the right care. And try and help providers like Dr. Thomas and others, if he's open to it, to understand what the price differences are and navigate the system. Do those three things, your prices, I think prices could come down. I think your cost could come down 20% or more in 12 months. This is not a fait accompli. It has to go up 5 and 10% next year. But it will if you don't come together through some group structure to restructure the pricing market.
Thanks, Shane.
Yep.
Great. Shane Cerrone, thank him.